Respected senior members in this August gathering, dear friends and colleagues, greetings of the day. At the outset, I would like to put on record my sincere thanks and gratitude to Professor Ilya Saltyrov, to Professor Kremina Petkova, to Professor Kamil Sarika, and other members of the scientific committee to have given me this opportunity to participate in this virtual meeting. I would like to share some tips and tricks regarding management of partial staghorn stone when you are managing it with standard PCNL. I have no conflict of interest to declare. See, specific issues pertaining to partial staghorn stones are these are large volume stones, they have extensions in difficult access areas, and they have some secondary stones. They may require prolonged surgery or ancillary procedures, and they may require multi staging also. Most of the partial staghorn stones, almost 70% of them, have associated infections. Either they are primarily infection stones formed because of urea splitting organisms, or because of their bulk and long stay in the pelvic system, they have led to infections. So these are practically infection stones having some amount of infection somewhere. They have higher recurrence rates, and hence complete clearance is very important. So what tips and tricks should be there so that we can remove these stones completely from the system, and therefore the agenda will be how to which are the tips and tricks for preoperative preparation, during operative procedure, and during postoperative care. Gearing up for managing staghorn stone begins from OPD itself. The first thing you should send the urine sample for culture and sensitivity because the report is going to arrive in 3 days' time. If the patient is having anemia, uremia, or any coagulation profile problems, those have to be addressed first so that the bleeding complications are minimized. Comorbidities and diabetes must be managed, and if there is a frank infection in the pelvic system, preoperative stenting or percutaneous nephrostomy and starting of antibiotics is a must. So, with all these precautions, you should do the case. The current AUA guidelines suggest that if the preoperative culture is positive, you should give antibiotics 5 to 7 days course before PCNL. And if the culture is negative, just a single dose of antibiotic covering gram positive and gram negative bacteria is enough. But we modify these guidelines according to our situations. There are two reasons. One, there is only 43.5% correlation found between preoperative urine culture and stone culture. The organism may be different. In spite of sterile preoperative urine cultures, septic complications have been reported in patients undergoing PCNL for staghorn stones. This paper, which was published in 2010, suggested that if you start nitrofurantoin 7 days in advance, the septic complications will be minimized. Another similar paper from the Indian Journal of Urology said that if you start ciprofloxacin, the septic complications will be minimized. So we follow this particular publication and we start nitrofurantoin 100 milligram twice a day, 7 days before. Culture specific antibiotic if it comes positive for minimum 5 days before. Whether culture is positive or negative, we will give broad spectrum antibiotic one night before and 1 hour before. And then as soon as the puncture is made, the first aspirate from pelvic system is again to be sent for culture and sensitivity. So we have to take so much precaution for the infective complications in staghorn or partial staghorn stones. Now coming to the operative procedure, what tips and tricks I would suggest? In the operative procedure, the first thing is choice of procedure. I will recommend for all partial staghorn stones to take up these cases with standard PCNL, making a track of 24 to 30 French. Many people have quoted this particular publication from Crows that if you increase the size of implant sheath, if there is a standard PCNL, the bleeding complications are more. To some extent, yes. But if you go into the finer details, if you make a track of 18 French or below, 1.1% patients will still require blood transfusion. But if you increase the size of employed sheets from 24 to 30 French, only 5 to 6% more patients will require blood transfusion. 94% patients, they will not require blood transfusion in spite of having a large tract. So I will suggest large tract because there are big advantages of larger tracts of standard PCNL, because it allows a better irrigation and clear vision even if you are using some instrument grasping forceps through the working channel. There is no rise of intrapelvic pressure due to adequate outflow. There is no need to dust or pulverize the stone into very fine particles which might slip into inaccessible calyces and may lead to recurrences. And if you use a larger tract, quick removal of less number of fragments will help you to reduce the time, operative time, and the blood loss. See, if a stone of 21 millimeter you have, this is a three-dimensional object like a cube. A 21 millimeter stone, if you think it has got only three fragments of 7 millimeter, it is not true. A 21 millimeter stone in all the three dimensions, if it is 21 into 21 into 21, it will have 27 fragments of 7 millimeter each. If you reduce the size to 3 French 3 millimeter fragments, the number of fragments will go as high as 343 fragments. And if you fragment the stone to 1 millimeter size, there will be 9,261 stone particles to be removed from the system. So complete clearance achieving will take long time, and even then you will be doubtful. So for any 21 millimeter stone, if you make a track of 24 French size, which is 8 millimeter in diameter, you can remove 27 fragments of 7 millimeter in quite less time. In comparison, if you make a track of 12 French sheets, which has 4 millimeter diameter, and you can remove only 3 millimeter stones through that, you will have to fragment the stone into 343 particles and have to remove all of them. This is sufficient statement to say that a large stone, a larger track is going to help you more. Second precaution what you should take when you are dealing with partial staghorn stone is you have to monitor the blood loss. And how do you monitor it? A neurosurgeon should not forget to note exact starting time of surgery. Your time should be less. You should also see the pulse rate on monitor yourself. Don't depend on the anesthetist. See what is the pulse rate at the time of starting of surgery after induction of anesthesia. We have done a study when we placed the irrigation bottle at an height of 60 to 90 centimeter from the patient and used 20 to 24 French nephroscope, we were flowing 350 ml of saline every minute. And if you add 10 ml of blood in 350 ml of saline, this is the color of irrigant which you will get. Most of us will just ignore it and call it a negligible blood loss, but it is 10 ml blood loss per minute. Now, if you add 15 ml of blood in 350 ml of saline, this will be color. And if you add 20 ml of blood in 350 ml of saline, this will be color. Most of us urologists are heroes, and we always assume that this is a negligible blood loss. But if you calculate 10 ml of blood loss which is continuing, and this is the color of irrigating fluid, you are losing, the patient is losing 600 ml of blood per hour or 1200 ml in 2 hours. So you should always be aware, and the first sign of significant blood loss is tachycardia. When the patient is under anesthesia, keep a watch. If he is not getting light, he is deep under anesthesia, and pulse rate has started increasing by 10 beats per minute or 20 beats per minute, significant blood loss has already taken place. Now you should abort the procedure, call it a day. So always remember to observe the blood loss and to reduce the duration of surgery and subsequent blood loss, because at least 10 ml blood loss is taking place every minute. You should always avoid multiple tracks. If you are using for partial staghorn multiple tracks, then definitely the blood loss is going to be more and complications are going to be more. So try to avoid multiple tracks. try to avoid the lengthy procedures like passing a flexible nephroscope and then lasing that small fragments and then trying to basket and removing them. It is going to take long time. Rather, what should you do is adopt saline push technique. And what is saline push technique? This is the concept of repositioning of stone fragments by saline jet to more favorable position for evacuation. I will explain it to you what it is. If this is the staghorn or a partial staghorn, it blocks the infundibuli and makes the hydrochalicosis and the stone fragments are formed or secondary stones are formed. Now, this infundibulum is usually wide in these cases. Once you have removed this staghorn through this particular amplard sheath, and this is the remaining fragment or a remaining stone, now there is no need to make another track or pass a flexible nephroscope and spend some time or do any other ancillary procedure. Just pass a initial puncture needle on the lateral aspect of the stone and give a saline push through this needle. Once you push saline through this needle, this particular stone will come in front of you, and then you can pick up this stone and remove from the same track. So this is the technique of saline jet, and you will be able to remove most of the partial staghorn stones completely through single track. This technique I've been teaching and training since last 30 years, and it is a very successful technique. Only rarely in about 10% of cases, when you give saline push, it may not come out or infundibular stenosis has taken place, and then this stone will not come out. You will need a secondary track or a nephroscope, a flexible nephroscope. See, all this stone bulk was removed from the same track, and these small stones were pushed into the system and removed from the same track, and complete clearance was achieved in very little duration of time. So, what I will advocate is make a single PCN track, and then go on using saline push technique through different calyces. All and whatever these fragments have gone there or some secondary stones are there, those can all be removed through this technique very easily. You can see one video of this technique. See, in this particular stone, there were many stones in the pelvic ileal system. All were removed through a single supracostal track, and after that, this particular stone was remaining. Now, how to remove this on the lateral aspect of the stone? It is a stone guided puncture, and then you should confirm in 0 degree and 30 degree of the CM position that you are at the stone lateral border of the stone, and then give a saline push, but before that pull out the implant sheath little bit so that it is not blocking the infundibulum, and then when you give a saline push you will see the stone comes in front of you. It will come in front of the implant sheath. Give 3 or 4 stone this saline pushes with the syringes, and the stone will come in your implant sheath, and it can very easily be picked up and can be removed from the same track easily, thereby reducing the time and taking out complete clearance of all the stones. Number three, how to prevent the sepsis. And there should not be any rise of intrapelvic pressure because this is the main cause of sepsis in PCNL. So you should always avoid high flow and pressure irrigation pumps for stone extraction, or you should not use vacuum cleaner effect for staghorn stones because this will cause sepsis. You should always use only gravity irrigation with a height of 60 to 70 centimeters of water, and there should be a minimum difference of 4 French between the nephroscope size and the implant sheath. When there is a difference of 4 French, there is enough space for the fluid to come out and there won't be any rise of intrapelvic pressure. Lastly, you can use the implant sheath with suction so that the intrapelvic pressure doesn't go high. So with these precautions, you should try to reduce the intrapelvic pressure and septic complications. Now coming to the post-operative care, all partial staghorn patients must be seen in detail after 6 to 8 hours after surgery because we know 10 to 34% of the patients they develop uncomplicated sepsis. They develop fever and within a day or two they become all right. But 1% of these patients they go into sepsis, and in them the mortality is 66 to 80%. So complicating sepsis must be identified, and how to identify that this patient is going to develop complicated sepsis, that is by quick SOFA score. This we should do ourselves, see our patient post-operatively. The quick SOFA was suggested by Sepsis 3 group in February 16 as a simplified version of SOFA. What you do is in this case, you go and see the patient, see the systolic blood pressure If it is less than 100, assign score 1. If the patient is tachypneic, his respiratory rate is more than 22 per minute, then assign another score and it becomes 2. And if the patient has got altered mentation, he is not intelligent, he is not as intelligent as before, he is not responding or not recognizing or a little drowsy, then assign another score. If his Glasgow Coma scale is less than 14, he then assign another score. So if there is any two of these findings are positive, there is likelihood that this patient will go into a complicating sepsis. So must send this patient to ICU and manage accordingly. So all these precautions will make your partial staghorn stone removal by standard PCNL very safe and comfortable. So take home messages will be: use standard PCNL technique for partial staghorn stones, give adequate antibiotic cover, tranexamic acid may be useful in uremic patients, keep a track of operative time and tachycardia, there should be low intrapelvic pressure throughout the duration, and look for signs of quick SOFA in postoperative period and take care accordingly. Thank you very much for a patient listening. Thanks and regards for your kind attention. Thank you. Thank you very much.